the start of some pretty big things that we feel really important to Aquinas. Several months ago, Mr. Knudsen, who's in back there, our president, Mr. Knudsen.
Thank you guys for coming out.
Made a commitment that Aquinas Schools would have mental health services provided to our students, with the belief that a child's mental and emotional health is a big part of their education. And the best way to do it, we've learned from experience, is bring someone right into the building. Don't make kids necessarily leave the building, have them right here. And so we've created this, been about 6 months in the making, creating a solid mental health program. And we've created a team with the idea of that this would not only just provide resources for kids, but that it would also provide resources for our staff as well, and parents. And part of that is we are going to do a series of educational topics to present to parents, students, and faculty. And this is really kind of the kickoff of that. And we're going to continue it into next year at different locations and address all the issues that are connected with mental health and mental illness. We put together a strong team here at Aquinas, and I'd like to introduce our mental health therapist, Rachel Fian. She has been serving here as a guidance counselor for many years, and she has stepped forward. She has the training for this, and under the supervision of Driftless Recovery, which is our partner, our mental health partner, Rachel will be leading a team of guidance people in our mental health program. So at this time, Rachel Fian.
Thank you all for being here tonight. So as Mike said, this is my 9th year here in the system, but I'm transitioning to a variety of different roles in that time. I'm excited for this opportunity. Obviously, I know many of the students throughout the system. I started at Cathedral and I've made my way over to the middle high school here. So that definitely helps with knowing the students and populations already. I'm a familiar face in the school, good and bad at the same time. Obviously, our office is filled already, so a different role for the kids to see me in, but I'm excited. We're starting to transition what that looks like, which isn't easy because I got to kind of kick some of them out as I'm off-site more, but I'm excited for all that's to come with this new role. I'm in several of the buildings already, seeing kids, having referrals come in quite frequently already, so things are up and moving. I'd like to take this time to introduce, I have our team here so far. So I'd like to put their faces up so that you're aware who's on our team and who we're working with as well. So we have Carrie Langan, who is the counselor at St. Patrick's in Alaska. Tanya Vaughn and Callie Reutemann, who are here at the middle and high school as part of my team. And as I transition fully out of the school counseling role, those two ladies will be taking on a lot of those duties. So you're already reaching out to them, continue to do so. Obviously, I'm here as a support as well. Hard to get rid of me. I'm excited for what this means. This is our first launch event. We're very excited to have Dr. Tom Trannel here. He and I work together at Driftless, so we see each other quite frequently, and he is here to present to you tonight on mental health in our youth. Tom.
I might say that we were very fortunate, first of all, to develop a partnership with Driftless Recovery. They are all in helping serve as consultants as well as a place for referral. And then by circumstance, Tom is a child and adolescent psychiatrist, and he caught wind of our program and has agreed to also serve as a consultant and advisor to us. So we are absolutely so fortunate that we have one of the best in the business helping us out here at Aquinas. Dr. Trannel.
Thank you. I'll start by apologizing. My voice is not good to start. I've never been invited to be on any choirs. And I got a cold this last weekend, so I'll probably be scratchier and gravellier than normal, so please bear with me. I am a psychiatrist, child and adolescent psychiatrist. We've been in the community for almost 30 years now. Our family were members of St. Pat's in Alaska. Our 3 kids attended St. Pat's, and I worked at Gunderson for 5 years when we came to town as in general psychiatry, mostly child and adolescent work, and then I went out on my own, and in the past 20-some years have worked all over the place in the community, and it's I always tell people it's a blessing, and I feel very fortunate to be in the field that I'm in, but it's because there's plenty of work, there's too much work, which is also an unfortunate thing, but for myself, I've been able to really kind of do what I want to do, and there's always opportunities. So I've, like I said, I worked at Gunderson. I've gone back and done some contract work at Gunderson when they opened up their adolescent unit. I've contracted at Mayo. I've worked with Family and Children's Center in a lot of different programming. Worked with La Crosse County and Family and Children's Center, La Crosse County. I've continued to work with in the whole 24 years now that I've been on my own. In different capacities. I've worked in corrections, in juvenile detention, in the La Crosse County Jail. I worked with different human service agencies. Been recent years down in Crawford County. I continue to work in Richland County. I've worked at a lot of the different, consulted at a lot of the different therapy groups in town. I've had a couple different private practices of my own up in Alaska and down on the south side of town here. And I've really enjoyed and found kind of my focus, which has been community-based work. I love to do team-based care, and really, when I heard about the opportunity coming about here, and I've been working with Driftless for a number of years, doing consultation with the team there, that I said, oh, that's something I'm very interested in, and I'd like to be a part of, and then it kind of fell in with knowing Mike and Mr. Knudsen, so I'm very happy to be here and be a part of this. So I've got a lot of material tonight. I'm going to probably speed through some of this. We've got, this is being recorded. There's handouts of the slides that are available for afterwards if people want to get them. There's going to be some things that we could talk the whole time about. I apologize about that. I'm going to be pushing through them because we want to have time for some question and answers at the end. Like Mike said, this is the start, and I hope that there's going to be other opportunities that I'll be here. I know our team will be presenting to the parents, to the teachers, working with the kids, working with the whole Aquinas community, and this is not a one-time thing here. We're going to be doing this over hopefully the extended future. So hopefully this is just a start, and we'll be able to talk more as we go on. So I think there's a couple of key points tonight. One is really that this is a team, and this is a collaboration. And I think one of the key points is that this isn't something that we're laying on the teachers or the staff, that we're laying on Rachel and her team, that we're trying to lay on parents, that this is something you have to do. Our point here is to educate, to support, to screen, to treat, to refer when we need to. So this is going to be hopefully helping and seen more as something that, again, is a support, not an extra duty or task for everybody to take on. We talked a little bit about, and I made these slides, a couple of my keywords that I love to say is multimodal and multidisciplinary. I just always like to spit that out. So, but I think that multidisciplinary, that, we've already heard in Rachel and her team, we're going to be working with all the teachers. We want to reach out to the parents, obviously, but it goes beyond that. I know that Mr. Knudsen talked about this came from the bishop and the diocese, and I think there's the support of the whole, of all the parishes and of our faith community behind this. I think we're also getting support. There's been some federal funding and state funding for school-based projects, and they're doing something in lacrosse community schools that we're kind of building on and tagging along with. So I think this is not just, there's a lot of shareholders in this. The alumni was very impressed about how when they tried to look for support for this, the great generosity that came about. So this is a big team. This is a big group, and everybody's got a stake in it. Tonight is basically an introduction to what mental health is, what mental illness is, what we can do. And I think I'll talk a little bit about my role and what child psychiatry is and how that works in the whole scheme of things. And again, we'll have time for discussion at the end. Child and adolescent psychiatrists are relatively rare. There's, again, kind of going back, there's lots of work. There's not a whole lot of people in the field. As awareness and things with mental illness, mental health have really expanded exponentially in the recent years in my whole career. We have not kept up with it from the field of child psychiatry. So the current estimates are 14 child psychiatrists per 100,000 kids. So we are spread thin. And one of the reasons that I went out on my own 20-some years ago is because I didn't really like the model that you kind of see in some of the big mental health, in the big clinic systems. And I have nothing against Gunderson or Mayo, and I have a lot of respect for people who work there, and I get my care there, and I think they do a great job. But they are stretched thin. If you call and try to get in with a psychiatrist, it's months and months. If you try to get in with a child psychiatrist, sometimes they'll say there's no waiting list. And so I really liked, again, going out on my own, being able to kind of say, this is what I want to do, this is how I'm going to do it. And I've been very lucky that I've been able to do that. But the way that things have evolved and progressed in the field is that it's much more of a collaborative approach now, kind of things we're talking about, looking at different models of care. So what I've really done in probably the last 10, 15 years is try to do this collaborative model. And I remember 20 years ago going over to the child specialty clinic at Mayo with Dave Capelli and Pam Hansen and Kelly Jakes and good people. They were having the Mayo psychiatry department kind of dissolved, and they were having their care done, child psychiatry care, by Bill Deering, a pediatric neurologist. And he left, he went out west, and so they had asked me about doing some contract work, and I said, I'd love to do that, but I know that I am not going to be able to serve the whole Mayo population. And there was a thing coming out about this collaborative care model where you embed a mental health person into a primary care clinic, and you're more of a consultant. You're not taking the day-to-day management of every patient. You're doing, you're giving your advice, you're doing some assessments, you're trying to help the primary care providers who are really, have that base relationship with a lot of these kids and families and along also with adults in general psychiatry. And so the model really made a lot of sense to me. But at that time, there was they didn't have, the system wasn't prepared for that. There was no way that they could bill for that or how they could fund that. And so it was kind of a pipe dream. But in the last 10 years, it got supported by the Affordable Care Act, and there's now Medicare, Medicaid billing codes for doing this. So it's really expanding in all the big clinics. I've done the training with Mayo here. I went on one of my other consultation or ventures on my own. I went there a few years ago and learned about their program. And so this is the kind of the future of what psychiatrists, child psychiatrists are doing. It's not kind of, they talk about silos. You're not doing your own work in your own limited patient population. We're consulting with other people. And so it makes a lot of sense to try and move out to where people are. And for kids, like Mike said, kids are here in school. This is kind of an ideal place. So this is not a new concept, but it's really gaining momentum and gaining a lot of support from the important drivers behind it, like payers and legislative stuff and those types of supports. One other point, my philosophy, and I don't think it's just mine, but I put up there the biopsychosocial model. Another one of my key fun words that I put into probably most every assessment that I write, along with multimodal, multidisciplinary, but biopsychosocial was drilled into me in my training. It's still very applicable. It takes different variations. It seems like every few years there's a new model of care that comes out, but for me, it kind of seems like a new play on the old theory. So biologic, psychologic, social, and what I definitely believe and what I've heard as well and been taught, spiritual fits into that social realm. So these are the areas that we look at for assessment, we look at for treatment, and so I think that's something I'm going to be mentioning several times, so I wanted to bring it up here. And I think it's something when we talk about our team approach, that it's not just biological, it's not just that it's all going to be, oh, let's get these kids on this. That's definitely not our plan. There's psychological factors, there's definitely social factors, there's definitely spiritual factors involved. And so I think, again, this team has opportunity to kind of come at things from multiple angles, and again, another reason why I'm very excited about being a part of this. Mental health. You can read this. I think this makes sense. I don't think this is anything controversial. I think that we're just putting a name to something that we all understand, that how important it is, what our attitude is, what our kind of our approach, our understanding of relationships, of emotions, of behaviors. So mental health is important at every stage of life, from childhood, adolescence, to adulthood. Youth mental health, again, I'm going to kind of fly through some of these. Youth mental health is obviously, again, this is not nothing groundbreaking, nothing, no light bulbs going off over my head with telling you this, but kids who have good mental health, who can handle stress, who are resilient, who can have coping skills and are able to relate and communicate well, do better. Do better in all different realms. Do better with school. Their grades are better. Decreased risk of risky behaviors, of drug use, of violence, of getting into difficult situations with sexual behaviors. So mental health is important to everybody. I don't think that that's a controversy. What is mental illness? Mental illness and mental health along the same spectrum. I'm a big kind of spectrum continuum kind of believer. Mental disorders, mental illness in kids, in adults, in everybody, are serious changes in the way people relate to the world. With kids, we're looking at how they learn, how they behave, how they handle relationships. When we're talking about mental illness, these are symptoms that are serious, persistent, that interfere, that cause disability and impairment in function. Important points here is that on the bottom there, mental health is not simply the absence of a mental disorder. So if because somebody is not diagnosed with a psychiatric, a mental illness, does not mean that they have great mental health. Again, the continuum theory. There are people who have that don't have a mental disorder that have a great spectrum of strategies and skills in the areas of mental health. And there are people with mental disorders who may have the same diagnosis who function at much different levels. So it's really a continuum. And I don't think, again, this is not groundbreaking. There are people with asthma who do very well. There are people with asthma who really struggle. There are people with all types of illnesses and disease states who function at different levels of the spectrum. So because somebody has depression doesn't mean that this person with depression has all the same problems and the same symptoms, same level of disability. So it's important to kind of understand things on the continuum and it's not a cut and dry, well, because you have this, that means you have this whole spectrum of issues. Or because you don't have a diagnosis means that you don't even have to worry about this. These are important concepts and things that we have to think about and incorporate into our understanding in everyday life. Yeah. So, let's see. So how do we diagnose? How do we come about to give the diagnosis of a mental disorder? Again, the biopsychosocial factors, the spiritual components are a big part of that. In psychiatry and mental health, we use something called the Diagnostic and Statistical Manual. It's currently in its 5th version, the DSM-5. When I went through my training, we were on DSM-3. The DSM goes back to the 50s with DSM-1. So it's something that gets revised. We get better understanding. Some presentation changes depending on different biological factors, social, psychological issues. So hopefully it gets refined, gets better as time goes on. It is not a perfect document at all. There's ongoing. I'm sure there will be a DSM-6. There'll probably be a DSM-7 in my lifetime. So it's something that's continually evolving. But this is what we use. It's a manual. It looks at different different symptom categories. We look at most things have to have a duration of presentation and duration of symptoms. And the key thing is that there's got to be that associated impairment and disability. So it's something that we're trained to do. You gather symptoms. There are screening tools. And you really try to look at things, training with knowing about development, knowing about different biological factors, weighing everything in, and trying to come to a educated decision about making a diagnosis. Some symptoms present definitely earlier on. And some disorders are more often diagnosed in childhood. Some are more often diagnosed in adolescence, some in adulthood. It kind of depends. We definitely take that into consideration. One of the things is that, and I think an important point is that many of the adults who have been diagnosed with psychiatric disorders will say that their symptoms started when they were young, when they were a kid, and they were never diagnosed. And there's a lot of studies and good science that shows that probably some of the half or more of kids who have a diagnosable mental illness are not getting treatment. So even though we'll talk a little bit in upcoming slides about how the numbers have grown over the years and how we're recognizing, we're diagnosing a lot more, there's still indications that we're probably not picking it all up. And there's obviously, we hear sad stories all the time. There are kids, there are people slipping through the cracks that we wish we could have helped earlier. So that's, I think, a very key thing. I also want to, I have a little blurb here because I think it's something that's very important. And just to, again, point out this is real. This isn't some kid going through a stage, or this isn't bad parenting, or this isn't some type of the kid's just not trying. Those rules definitely are part of a big assessment. We always try to assess all those types of things: motivation, the social factors. But we look at mental illness is a non-discriminatory thing. There are I've definitely seen, and studies and research shows that there are good kids from good families, and that are smart, and that still get diagnosed, that experience mental illness. And so it's not something that just needs a good kick in the butt. And again, sometimes if you go through an assessment, you can understand it, and I will recommend, yes, we need to put some structure, some limits, some discipline here, but that's not a cut and dry. This is what this is all about. Mental illness is real. It's been around for a long time. We know that there's these biologic components. They can run in families. They're genetic predispositions. And so I think we really have to, I think if there's one key point that you can come out of this with is that this is a no fault thing. This is something that people come to honestly, and that we have to recognize that and accept that. So, what I was going to read, all children get sad, anxious, irritable, aggressive at times. Many find it occasionally challenging to sit still, pay attention, interact with others. In most cases, these are just typical developmental phases. However, such behaviors may also indicate more serious problems in some children. So, we go through our assessment. We look at these different realms. We look for serious, persistent problems, disability, problems with function, impairment in their interactions that persist. And we try and I think making a diagnosis is not a condemnation. It's not this is a way to open up doors to, yes, this is a problem. Let's recognize it. Let's get the treatment involved. Let's try and attack this with what we can. I think there's, the bottom line there, I think, is another key point. Obviously, the worst case scenario for a psychiatrist, for a parent, for a family member, for a community member is somebody dying from suicide. And unfortunately, it happens, and it's happening more often than it has in the past, and it happens to kids, and it happens to adolescents. Obviously, it happens to adults. But if there's ever a concern that your child is unsafe, that's not something that's something to take seriously. And there are times where I treated people over the years where they have chronic thoughts of this, and we develop plans. And it's not just because somebody says that they're having these thoughts or thinking about this does not mean that we're putting you away, we're locking you up, we're pulling you out of everything. But that's a time that they need to be assessed by a professional and to decide what we need to do to keep somebody safe. So that's obviously a time when you need to reach out. You need to try and get the help you need. We need to do what we can to make safety the bottom line. So statistics, I'm not going to spend time with. There's several stats. I've got several different types of looking at statistics from various angles. The statistics show that we're diagnosing mental illness much more over the years. It's grown in the past 50 years. It's definitely grown in the last 30 years, and it's really grown in the last 20 years, and now in the last few years, it's gone through the roof. So, and there's different, I think people can argue or talk about, well, this statistic says this, and this one says that. They're looking at different populations. They're looking at reports from parents. They're looking at different types of settings where they're doing diagnosis. So there are going to be some variations, but overall, there's consistent science showing that mental illness is a growing concern. We're diagnosing more, and the ages are going down. We're definitely seeing things in kids and adolescents. The pandemic didn't help any. And there's studies of prior pandemics have shown that, and disasters have shown that there are short-term and long-term effects. I think we're continuing to see that. I think we're going to continue to see that for years to come in all of us, and definitely kids who were affected by the pandemic. So, we hear things like a mental health emergency, or we've got a mental health crisis, and sometimes I think we just hear it so much that it goes right by us. So I think it's worthwhile to try and address that or talk about that. I definitely believe there is a crisis. The numbers, the statistics support that. There was a consortium of the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, Children's Hospital Association, jointly declared a national emergency in child and adolescent mental health in 2021. The numbers, the people, the community's support that there is definitely a crisis in mental health among kids and adolescents. Next, I wish I had the exact answer to this. I do not think there is an exact answer to this, but why? And I think it's, I'll use another one of my multi-words, I think it's multifactorial. I think that there's a lot of things that lead to us recognizing, diagnosing, being more aware. And part of it is just that, we're more aware. A lot of stigma of mental health has dropped. There are still a lot of old held beliefs about mental illness that we have to fight through. It's hard to, it's not like it's something you can see externally all the time that's very obvious to people. So I think it takes a little bit more awareness and understanding to appreciate that it is real, but those barriers are dropping, and I think there's the shame has dropped. The support of family and friends has improved, so that people are coming forward more, seeking out help, encouraging others who they're seeing these issues with to get help. So people are coming out forefront, bringing themselves to others to get help more than they were in the past. So that's definitely part of it. We're doing better with diagnosis. We're doing better with training our medical providers. Again, we don't have the number of psychiatrists, child and adolescent psychiatrists that we need, but primary care providers are a lot of times our first, second, third line treatment at this stage for mental health, and they're much better trained than they were in the past. It's not something new. I'm 30 years plus from medical school. We all had a standard rotation in psychiatry as part of our third year of medical school. That it was something that we were aware of. So, and it goes back before my generations. So it's something in the medical field that's been realized for a long time. Probably should have said this before. Psychiatrists are medical doctors. A lot of times there's confusion about psychiatrists, psychologists, therapists, counselors, what we all do. Psychiatrists are, I went to college undergrad, I went to medical school. My last year of medical school, I was still going to be an orthopedic surgeon, and figured out that wasn't for me, and went back and was looking and really enjoyed psychiatry and went into psychiatry. So then did a year of a general internship here where I was working in ICUs and on medical units, working in pediatric and neurology departments. Psychiatrists are medical doctors. Some people still don't believe that, even if I tell them, but I have an MD behind my name. And then after that, we do the internship year. I did 3 years of general psychiatry. If you just follow the path of general adult psychiatry, that's a 4-year path. If you're going to do a child and adolescent fellowship, that's a 2 years extra. So you get an extra year dropped off of that general psychiatry. So that was my path. And then there's national board certification. Psychiatry is boarded under the psychiatry and neurology are the national boards. So it's again, it's legit, it's real, and the medical field understands, appreciates, and thank God they do, because they are doing a lot of our mental health assessment and care. And again, with these new models that we're developing, they're an integral part of the team approach that we have for treating mental health and assessing it these days. So we're better at diagnosing. Some of the diagnostic criteria have changed, and they talk about, and that's changing. When I was first starting out, bipolar disorder was getting diagnosed like crazy in kids, and we've kind of backed off on that, and thankfully that's come under some control over time. But then autism kind of went through the roof, and the numbers of autism, skyrocketed, and the percentage of autism really went up. And so, big questions: is there something causing autism? What's behind this? Probably changing in diagnostic criteria. Autism is now an autism spectrum disorder, and so things that used to be called Asperger's syndrome and high functioning autism are all within that category. And so diagnostic categories, that DSM, changes in that will change how many people are being diagnosed. Some diagnosticians, we have screening tools, we have the DSM to kind of guide that, but some people will just, and I think it's kind of human nature, who've been in the field for a long time will say, oh yeah, that's depression, I can tell that's depression. And maybe they're being a little too nonchalant about it, and maybe they're making diagnosis without really going through an assessment as they should. So that can be part of it. The other thing I think is a key thing is that legislation, advocacy have really grown, and there's more funding. When I started out, insurance plans had kind of what they cover for general medical problems and what they cover for mental health. And there's been a big push against that, again, thankfully, because now mental health is being recognized by insurance and third-party payers as mental illness is a real thing, and it spills over, and there's a lot of overlap with other types of physical health problems. And if you treat that, you're going to see a lot of improvement in other areas, and so there's a lot more funding. And if you fund it, people will, if you build it, people will come. That helps with people coming and getting treatment. And so I think there's a lot of things that feed into that. And I guess a big point that I would like to make sure to make is that we always come up and there'll be a slide here about social media, and I'm not a big fan of social media, and I think there's a lot of problems. I think I think technology is great, and I think there's a lot of pluses and benefits and things that you can get out of all the expansion in technology, but there are also downsides that are pretty obvious. And but to say that it's all because of social media, I think is really too simplistic and really kind of steps away again from. I'll get to my slide here because I think I have a decent. Okay, that was what we already talked about. Again, Surgeon General issued an advisory talking about the crisis and talking about the many different factors that go into what's behind mental illness. Social media. Definitely, there are consequences associated with overuse of social media. The last paragraph, I think, is, and I kind of hesitated when I saw one of our colleagues put these slides together, and I had it written a little bit differently. But there is good research, and I've had several people ask me recently. There's a lot of popular psychiatrists and psychologists and therapists out there kind of selling books and talking about this is what's causing everything. And there's been a guy lately that I've had a bunch of questions about, and I don't think we can lay it all on social media because I think there's definitely other things going on underneath of it. People who are already at risk, definitely this can make things much worse, and it can definitely cause problems for people who don't have a mental illness, but it can definitely cause problems with people's mental health. So I think, again, there are definitely risks there. There are things that we have to be concerned about, but I don't think it's the reason for all of our increasing problems with mental health and mental illness. So what can we do? We're going to try and get at this from different angles, like we talked about, our team approach. We're going to educate, what we're doing tonight, what we're going to continue to do with the different parts of our big team that are trying to address this. We're going to try and promote mental health. We're going to try and screen and recognize problems and mental illness. We're going to set up assessment systems within our schools, and we're going to assist with targeted interventions individually, with groups that are at risk. And then we're going to support with referrals where needed. We're not going to be able to do everything here. But I think, again, one of the things that we can do, going back to those collaborative models, and one of the things that hopefully I can help with, that I've been trying to do this in different places that I've consulted with in town over the years, is if we have something that needs to go to another level of care, if we need somebody that needs a prescription, well, we can work. We've got pathways, we've got providers that we know and we can work with that appreciate our input, that really like to hear something from mental health professionals, rather than primary care providers are stretched very thin as well. So we want to try and, again, not lay more stuff on them, but support them. They're not working by themselves, and try and get kids, get staff, get families, whoever needs to those health areas that can do that next level of work. That's where Driftless comes in. Driftless is going to be providing some of that, but there's also going to be probably times where we need to talk to prescribers or primary care providers. Sometimes we may even need to look into what the options are for different treatment settings elsewhere, replacements. Hopefully we don't get to that, but again, that does happen, and so this is something that hopefully our collaboration can help with. One of the things here at the bottom that you'll see several times through here, and that I really appreciated coming into this, and that Mike talks about, is connections and relationships. That's key. So that's going to be something that we're definitely going to try to build, and I think that's one of the things, and jumping ahead of myself, that schools are a great place to do, because and this approach, parents are the your child best. I've said that thousands of times over the years. You are the expert in your child. You help me understand what's going on. You're a huge factor in their life. So your role, your input, your participation in this is going to be crucial. Teachers have contact multiple hours a day, most days of the week, for a good chunk of the year. So much more information than I can gather in a 60 or 90-minute assessment, or a follow-up appointment every, maybe every week or two if we're lucky, but a lot of times every month or two. So input from everybody is going to be important. But you can look at this again more so, but I think it's everybody has a role. This is a team approach. Schools are where the kids are at, so we should bring our treatment to where the kids are. That makes sense. But schools do much more than just house our kids during the day while we're off doing other stuff, obviously. So I think that schools are a great place to do this. And it's people who want a relationship with kids, people who are in this field because people who are working here because they want to help kids, and this is something that's definitely fits in with that whole mentality. It's not something new. It's being done. We do studies show that kids are getting mental health services in schools as much as they are in specialty clinics, more so than they are in primary care clinics. Not because we have more providers, but I think because we have kids here, we have more access, we're picking it up more because of those relationships and those connections that we have. The goal is not to increase the work for schools, support with education, referrals, and collaboration. This is stuff that I think we've already been talking about. I'm just going to jump over it and get to I think, kind of some of the meat here at the end. What is the parent's role? Again, parents play a crucial role in their kids' development, in their kids' health, in their overall function. So we want your involvement. We want you to be involved with school. We want you to be involved with this project. Research has shown that when parents are involved, kids do better. Get involved. Try and learn. Try and talk to your kids about this. This is not a taboo subject. Talking to a kid about mental health, mental illness, asking somebody about suicide is not going to make them have those symptoms, is not going to make them kill themselves. So do not be afraid to ask. Last point is that parents need to take care of yourself. I do, most of my work now is in consultation. I work with busy therapists and providers all the time, and we talk about if you're not healthy, it's going to be really hard to help somebody else be healthy. If you don't take care of yourself, how are you going to take care of somebody else? That definitely applies to parenting. So we know, kind of going back biopsychosocial, this stuff runs in families. That's not a shame-based thing. There are tons of books and literature and reports of people with mental illness who are brilliant and at the highest level of all different fields. It's not a shame thing to say, you know, people come out and are spokespersons all the time in the past for diabetes or heart disease or things like that. We're seeing more and more of that with mental health now, and I think parents can definitely be a good model for their kids if they recognize, if they get treatment. It's going to make you a better parent. It's going to help your kid as well. That's it.
We have some time for questions for Dr. Trannel or Rachel or myself. As Tom said, this is not a one and done, and some of the things you get into, for example, like the social media thing, we'll have a night just talking about that in mental health and other topics along the way as well. So we hope to really push this thing. I just want you to know how committed Mr. Knudsen, this diocese school is to